Good evening, everyone. I am Brother Dr. Jeffrey Sterling, Surgeon General for the Alpha Phi Alpha Fraternity Incorporated. Good evening. I hope you are in good spirits and ready for another exciting and informative Surgeon General Initiative webinar this evening. On behalf of our General President, Brother Willis Lonzer III, of course, we bring you greetings. In introducing this topic, I just want to express how fascinating this topic is in general and in particular, because if you've ever heard me talk about healthcare on any platform, including this, you know how big I am on empowering you to be a better steward of your own healthcare. And the whole concept of what we're talking about today with patient-centered efforts is really meant to help you individualize your specific health needs and your desired health outcomes. However, there's a fork in the road regarding whether you're doing this yourself and am empowered, or whether hospital systems actually take on the initiative to try to make that happen for you in the care that's being delivered. I think that the way that this particular webinar is set up is quite fascinating because unlike any other forum you'll come across anytime soon, we literally have a chief executive officer of a healthcare system here. We have a chief operating officer and a vice president of commercial marketing. So looking at it through the eyes of this group is quite fascinating. And of course, I'll come back at the end to talk about what you can do to be empowered. So without further ado, allow me to welcome back tonight's moderator. By the way, before I do that, I actually want to take a moment and just bring special greetings and thank you to Iota Rho Lambda for taking the initiative to have this event occur this evening, and extend the invitation to all other chapters and interested parties out there to suggest topics for these conversations. With that said, again, I want to welcome back tonight's moderator, Alpha Phi Alpha's Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha Phi Alpha and is currently active in Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. He is board certified in internal medicine and in geriatric medicine, and is a fellow of the American College of Physicians and the Society of Hospital Medicine. Dr. Narcisse, have a fantastic event, and I will talk to you a bit at the end.
Thank you so much. Yeah, patient-centered care is something that I have a particular passion about. My initial training was in primary care, and so primary care doctors often talk about the tenets of patient-centered care, where we talk about contact with the patient, comprehensiveness, coordination, and continuity. But increasingly, I think that there's a recognition that patient-centered care involves so much more. It involves providing care that's respectful and responsive to the individual patient's preferences, needs, values, and ensuring that patients' values guide all of our clinical decisions. So this is the kind of conversation that we're going to have tonight, and we're going to talk with an esteemed set of colleagues. First, I'd like to introduce Brother James P. Young, Jr., PhD. He's the Chief Executive Officer of Concordant Health Solutions. Brother Young is a certified professional in healthcare quality, assistant professor and associate department chair of healthcare administration, business administration, and health resource management. Worked many years as a medical device consultant in cardiovascular disease, but really focused on racially diverse populations. So I think that his insights would be very, very helpful. Additionally, I'd like to introduce Brother Santosh Pierce, FACHE, Chief Operating Officer of Holy Cross Health. He's president and co-founder of the People's Executive, a nationally recognized board-certified health executive, 4-time recertified fellow in the American College of Healthcare Executives, and a recipient of the Regional Early Career Executive Healthcare Executive and Distinguished Service Awards. He's one of the top 25 emerging leaders as defined by the Modern Healthcare Group in 2021, and is also a recipient of the University of Southern California's Price School 90 Pioneers in 90 Years Award. Welcome, Brother Pierce. And additionally, I'd like to welcome Brother Carl McGowan. Brother McGowan is an MBA, CHFP. He's Vice President of Commercial Marketing at Guidewell. He's a certified healthcare financial professional, member of the New England Journal of Medicine Innovations Insight Council and American College of Healthcare Executives. Additionally, Brother McGowan was one of the individuals in my own wedding and is a newly minted father for the second time. Welcome. I'd like to start the conversation and ask the panel if someone could talk a little bit about the differences between patient-centered care and non-patient-centered care.
I can take that, Brother Narcisse. Again, this is Dr. James Young, and the key difference between patient-centered care and non-patient-centered care is that with patient-centered care, patients often are the authors of the treatment regimen. Patient-centered care only works when there is a line of communication between the providers and systems, as well as having a patient who is confident enough and skillful enough to be able to articulate to a team what they would like in the way of interactions, communications, clinical outcomes, and so on. And what makes patient-centered care work is that there's more information available today to help patients compare physicians and hospitals to make informed decisions. Non-patient-centered care, or what we used to call fee-for-service type care, was based on physicians and hospitals getting paid for volume. The more they did, the more they made. Now, under the new value-based payment models and patient-centered care models, they get paid more by doing things right, not so much by volume. Volume is a factor, but the main factor is what we call the triple aim. Low-cost care, high-quality care, and care that delivers a positive patient experience for the communities that these providers and hospitals serve.
Yeah, I'll be happy to add that, Dr. Narcisse. Patient-centered care, I define that as really focused on the patient and their needs. They're about empowering patients and viewing them as care partners. So, any of the major organizations you tap into, New England Journal of Medicine, Institute of Medicine, they really talk about viewing patients as partners. So from my perspective as a hospital executive, how do I partner with physicians to make sure we're providing that patient-centered care? And so very top of conversations we have around the table, social determinants of health, right? It's bigger than just diagnosing the patient when they come in for care, but what are we doing with that patient, right? You're discharging them. Do they have transportation to get back to their physician office, right? Healthy eating, diet, exercise, the list goes on. And the second thing I would say, Joint Commission, who we're all very familiar with, unleashed something probably about 10 years ago. They came out with a pocket guide for culture-sensitive care. And it's something my organizations we've tapped into and really kind of use to look forward. And that pocket guide really evaluates ethnicity and races and how you interact with them in terms of providing a positive patient experience. So in summary, empowering, guiding, and viewing patients as partners in their care.
I think that's great points. I'd probably just add on to that too. I think one of the key areas now is that we're moving healthcare into where other parts of the economy are, which is more engagement between the consumers, which are the patients, and their physicians now. It's not your grandfather's healthcare or your grandmother's healthcare where you'd walk in and they would tell you what you need to do. There's a lot more engagement, interaction, as Brother Pierce, Brother Young pointed out, too, where people are more prepared when they come into the office visits. The physicians and the hospital systems are taking into consideration, as well as the insurers, what's the health history of that individual. They're coming to the table with their concerns, with issues that they want to address, their health information, and it becomes more collaborative as opposed to a one-sided conversation.
I think we see that on a regular basis, and I think that there's a broad sense that that's the way that healthcare should work, but it doesn't always seem to operate that way. There always seem to be barriers to this, whether it's time or resources, experience, or the way that the healthcare system has evolved. what type of resources would you say that you would want to tap into if you're not getting the kind of patient-centered care that you're looking for?
Yeah, so there's an organization called NCQA, or the National Center for Quality Assurance, where the acronym is. And they have something called patient-centered medical homes, right? And where we talk with consumers, a lot of them aren't aware of these patient-centered medical homes, but it's kind of a best practice. It's a resource that you can really tap into. Regionally, you can typically search PCMH in Google, and you'll typically get a number of health centers kind of in your area. So that's one thing I would tap into. Culturally competent care, right? So when I think about providers, I'm thinking not just about physicians, but I'm thinking about hospital providers as well, really educating consumers. CMS, the Center for Medicare and Medicaid Services, has something called the STAR rating program. And so most people can obviously understand stars and grades. So that's something you can also view. It's on a scale from essentially 1 to 5. So you can typically view hospitals and also nursing homes. And the last I would say, people are also very familiar with grades. How do you evaluate the hospital down the street, hospital A versus B versus C? And we have something called Leapfrog. And so Leapfrog basically looks at quality indicators twice a year and rates hospitals from a grade of A to F. So that's something else you can really tap into, not just from the physician side, but also from the hospital side as well. And last but not least, social media, right? And so we talk a lot about competent providers. Your family member is the best, sometimes the best resource in terms of culturally competent care providers as well. So those are just a few that come to my mind.
I would like to add to that. I am certified by NCQA as a patient-centered medical home content expert, and I've helped a number of practices around the country convert and establish themselves as patient-centered medical homes. It is a very, very involved process, and there are a lot of things that those practices have to demonstrate, both in the way that they deliver care and the policies that they put in place for care. And as a certified professional in healthcare quality as well, I get the opportunity to work with the providers to not only look at patient-centered medical home transformation as a process that will lead to better care and in some cases greater revenue, but it also has a lot of elements in that process that pertain to the same things that Brother Pierce was talking about. How well do you communicate with patients? What kind of policies and procedures do you have in place to determine social determinants of health? And what kind of strategies do you have in place to identify those who need assistance with social determinants of health? Do you collect data and do you monitor data on healthcare disparities? You all know COVID illuminated a lot of healthcare disparities, particularly among people of color. So as a patient-centered medical home, how well are you monitoring that to make sure that you're delivering care equally? And in the most simple terms, how do you find a patient-centered medical home, or how do you find a practice that is skilled in delivering patient-centered, culturally competent care? Ask them. Just tell them, I'm interested in understanding how you operate, and are you a patient-centered medical home? Do you adopt patient-centered principles? If so, what are they? And just have that conversation. And once again, it goes back to what we said early on: being an engaged patient, being a knowledgeable patient, and in today's terms, being a skillful consumer.
Father Young, what would you say is the most common barrier to that conversion for a practice or a health system?
It's twofold: time and money. It takes a lot of time to put together all of the documents and all of the policies and all of the infrastructure to become a patient-centered medical home. And it's not free. If you hire someone to help you, then that's a cost. If you do it internally, you're going to have to set aside, time and resources within your organization to achieve that. And quite frankly, it's a little risky because you can do all that and still not get approved as a patient-centered medical home. So you'd have to reload everything and try again. But because payers, and I know Brother McGowan can speak to this as well, payers and insurance companies now are paying practices more money if they become, and when they become, a patient-centered medical home in terms of higher per member per month payments. And so there is a financial incentive to become a patient-centered medical home, but it can take quite a while, and it can be a little costly.
I'll tell you that I just left a patient's bedside in the past hour, and I had a almost hour-long conversation with a family with a complicated issue around dementia and transitions of care, what type of support would the patient and the family need going forward. And it was an hour. It was an hour that doesn't have a historic payment mechanism, and so that's one of the things that we often see. I asked the family, why have you not had this conversation before? They said that they just really couldn't connect. They weren't able to connect with individuals in their past to have this conversation, even though they've been looking for this kind of a discussion for many, many years. So I really can appreciate the appetite for the type of care that we're describing, particularly as it talks about individuals in communities that have not always felt heard by the medical community. Wonderful. We've got a series of individuals who represent a whole host of healthcare executives, and I'd like to know more about how the insurers and how hospitals really make the transition to being culturally competent.
Yeah, I can go ahead and start on that. I think you began to allude to it a little bit before too. The first part with the insurers is that, one, we're looking to diversify our network of providers. We realize that cultural competence starts with the providers, and in many instances, as we look through our networks, and this is across our industry, we don't see the diversity that we'd like there. Now, part of that is the workforce. When you look across the different specialties, providers, systems, they're just not the traditional workforce of the size of minority populations that you would want to see there. Does that mean that only African Americans can provide that quality care? No, but in instances where there are this is not that level there, we are looking to do more training in conjunction with some of the hospital systems in terms of cultural competency and care, in terms of that patient-centered care of what consumers need, their backgrounds, their ethnicities, their preferences there, that they can engage in it. And then secondly, just really working with the health systems themselves in order to build our plans around promoting that culturally competent care. You begin to allude to it a little bit with the patient-centered medical homes, but accountable care organizations, taking into account the way we require payments for things, prior authorizations, removing a lot of the barriers that Brother Narcisse, you described between the patient and the provider, to have those type of conversations as to the requirements that they need. And it's going to be different. For example, as you pointed out a little bit before, my wife and I were very adamant about having an African-American OB-GYN for our son's birth. And, the things that she talked about during our discussions and some of the things that we had during the pregnancy were things that were very culturally relevant to us that, other physicians may not have known. And so those are the types of experiences that we look to engage from a payer perspective in order to enable hospital systems and providers in order to provide to their patients and members as well.
I still think that there's an opportunity, because I think that representation still matters. And I think that this is an issue that doesn't have an easy fix. But if you look at my individual condition, I'm an African-American male physician. That represents about 5% of all physicians across the United States. So if you have a background that's similar to mine, and you wanted to have a conversation that is seamless, and you're looking for a provider that shares that demographic, it's often very, very difficult. And because of the way that medical education works, you've got to go to high school, you've got to go to college, then you've got to go to medical school, you've got to go do a residency, you might have to do fellowship. To actually, I go from an individual who might be interested in being a physician to the point where they're actually in practice represents a huge investment of time resources by the community and financial resources by the individual and community. So I still think that there are opportunities to expand such programming. I know that Xavier University, my parents' alma mater, is partnering with a hospital system in New Orleans, which is Ochsner, to try to expand opportunities for individuals. So I think that that's a great step, but I think that there's a need to expand such programming across the country right at a time when there are forces that are actually that have led to a diminution of the diversity in our communities. So I wonder if there are opportunities that the community or the healthcare administration can speak to, trying to encourage the development of diverse populations in our healthcare providers.
So Brother Narcissus, I work for Trinity Health, so we're a large faith-based system across the country. We have about 88 hospitals, 21.5 billion in revenue. So we're in pretty much a lot of the major markets, not every major market across the country. And so one of the things I've been impressed with in terms of culture, competency, care, our CEO, system CEO, is a white male. And actually 2 years ago when I arrived at Trinity, they installed something called anti-racism training, right? So I'm thinking, like, where is this going, right? So it's a 2-hour, it's a virtual course, but you're basically interacting with folks from across the country. But they're serious about it, right? They're going through cultural competency in terms of trying to address various stereotypes. How do you interact with certain patients and cultures and ethnicities? And now it's starting with the leadership level, but we're trying to get to the physician level, right? That's probably the most critical. But I think it's a great start. We've done that across the country. It's also reported to the board. So it's not something that the CEO just kind of put out himself. It's reported up to the board, and all we call our regions ministries, they're all expected to kind of contribute and kind of play their part. And the second thing in terms of cultural competent care, I think, what health systems can do, what we're doing here locally, currently in Florida, we're moving to Georgia next month, but one of the things we did, we invested in a very underserved area in South Florida, Fort Lauderdale. It's actually the site of the first Black hospital that existed here in South Florida. So we went back into the community. We've hired people from the community and people that look like the community members. And so that's kind of our, two of our initial steps that we're taking at Trinity, at least from a national level as well as regionally as well.
Brother Narcisse, when we're working with providers and hospital systems, we try to keep it simple. And that is, we adopt the Stephen Covey model. And that is, cultural competency begins with first seek to understand and then seek to be understood. So that is pretty much the foundation of how we approach this. And secondly, one of the advantages of patient-centered medical homes and patient-centered care is care coordination, meaning that your primary care physician, who you probably will see most of the time before you get symptoms, you can see them with symptoms as well, but they're more involved in helping you to avoid illness and avoid unnecessary complications. Where the wheels kind of fall off is when you're referred to a specialist. And normally when you get to a specialist, there's something kind of serious going on. Either there's a serious illness or there's serious symptoms. And sometimes the treatment of the interactions with a specialist is not quite as warm and fuzzy as it is with a primary care physician. So when you have a primary care physician who is skilled in patient-centered care, that person will be your quarterback, because that person will make sure that wherever they send you for specialty care, that you are treated the same way that they would treat you, because there's a business model, meaning that the specialist relies on the primary care physicians to refer patients to him or her, and that's a revenue stream for them. So they really don't want to upset that primary care physician by treating their patients in a uncomfortable or disrespectful way. But again, going back to what we were saying early on, you have to be conversant and vocal. If you go to a specialist and you're referred to a specialist by a primary care physician and something doesn't go right, you're not treated right, things are making you feel a little uncomfortable, feel free to let that doctor know, and then also let your primary care physician know as well, because my wife has a primary care physician, and she's a pit bull. I mean, she's like, if I send you to anybody and you don't like the way they treat you, you call me while you're in their office and I will intervene immediately. So that's, again, one of the advantages of patient-centered care and being a knowledgeable and engaged consumer.
We're seeing a greater demand for this communication and coordination. And again, I think that's a big part of patient-centered care. And that's one of the things that attracted me to primary care, originally geriatrics. And now I practice in a hospital, and patients are obviously ill. They are even more vulnerable than they are in the regular course of an office visit. And there is an almost insatiable desire for communication with the patients to the providers, to the families, providers to the patients, and a growing recognition that they're expecting more communication provider to provider. And so as a hospitalist, one of the things that I try to do is provide that quarterback role where I'm talking to people over the course of the day. The role I have is very analogous to the primary care provider, very analogous to other industries where you might be the general contractor who's coordinating all of the subspecialists, the trades to try to get the house built, the building constructed. And so that's the role essentially that I have. My career has become essentially a professional communicator between the patients and the subspecialists, because we've all learned to communicate, and we think in medicine, and it's sometimes difficult to translate that back into English or the preferred language of the patients and the families and communicate very effectively. And I still see that based on the kinds of questions I get and the feedback that I receive on a day-to-day basis, that there's an appreciation that we've done so much more than we've ever done in the past, but not nearly as much as patients and the community would like for us to have. Are any of you providing training to providers, to communication to providers, to enhance their cultural competency and their ability to provide a patient-centered environment?
That's our wheelhouse. That's what we do as an organization, is that we help providers develop strategies to create not only a strategy for cultural competency and patient-centered care, but a culture, beginning from just how you write your mission statement. Is your mission statement consistent with patient-centered care, high-quality care, cost-effective care? What does your mission statement say about your organization? And then, how do you train your staff? What kind of tools and mechanisms do you use to train them, and what is your message? And how do you make sure that everyone in the organization fully understands what a patient-centered medical home is, why it exists, what are the benefits to having it, what are the benefits to being a part of one, and as far as cultural competency, make sure that your strategy and your training and development process improves or includes education on why cultural competency is important. At the end of the day, healthcare is a business, and these patients are customers, and they're paying customers in many cases, or there's non-compensated care, but for the most part, it's not a business where people are going broke a lot. So there is revenue coming from the people who walk through the doors, who pay the salaries and pay for the infrastructure of the practice. And it is important, it's very important for our physicians, our customers, to understand that today your performance is being compared to other similar practices. You have like a triple whammy. The first one is that everything you do pretty much is going online. So as Brother Starnish would say, or shared with us just a little while ago, there's a STAR system, and there are all kinds of comparison systems out there to help people determine how well you're doing without ever talking to you. They can just look at your record and look at some of the data. That's number one. Number two, that creates a sense of competition. And that's what the Affordable Act was really somewhat designed to do, was to increase the amount of competition between providers and systems. And so that's the second part of that issue. And third, if indeed you are not able to transform culturally competent patient-centered care into a business model so that you create that culturally competent patient-centered care culture, then over time you are going to lose market share. So we come at it strictly as, looking at healthcare as a business, looking at your leadership style as one that should be built around a laser focus on patient-centered, culturally competent care to maximize the value to not only the community that you serve, but also the value to your organization.
And I have to.
Brother McGowan next.
Very well.
Sure. I was going to say, I have the utmost respect in this instance for Brother Pierce, because he has one of the toughest jobs of all of us. On one hand, he is working with the staff and the physicians in the hospital to basically transform the system. We're in the process of moving now from a sick care system, which is, as this Brother Young pointed out before too, how do you increase the volume of things? This is the business model. How do you do more services and procedures to drive more revenue? But moving more towards a healthcare system where it's based around outcomes, it's based around keeping people healthy. And so having that transition within his hospital at a local level, but then also dealing with us from the payer side of, how do we change the payment model where, the physicians and the hospitals are compensated for keeping people healthy, as opposed to looking at the never events that are not occurring. And so it's difficult in that sense. And so one of the things that we work on from the payer side is working with Brother Pierce and his counterparts is to understand, what are the obstacles that we are providing or causing that health systems there that we can remove? Can we help out with the technology to make the communication better between the physicians? Are there things that we could do to make information sharing better that can help them provide as much information as possible, whether it be, the pharmacy, the prescription work for these patients that they have, so that they can get all the information about that patient or that member that they need in order to keep them healthy.
Brother Pierce?
Yeah, the question you asked about what we're doing for physician training, we're not there yet, right? So the training I talked about, we started with leadership. I think that next evolution is to get the physician training. And Brother Narcissus, you're a physician yourself, so I know right? So a lot of physicians will come with the approach that, am I getting paid for this, right? So you're still dealing with some of that as well, right? Not out of the goodness of their hearts. And that's not for every single position that exists, but you still have those group of physicians that do kind of have that same belief. So we got to kind of get past that. I think Trinity's taken at least the initial step with leadership. We'll eventually get to the staff level and eventually to the physician direct care providers as well.
I think a lot of organizations find it easier to train the staff than to educate the physicians, because they have more control over the staff's time and attention. So that's a thing that we see all the time. In my hospital, one of the initiatives that's been that we're trying to roll out is better electronic communication, which to me seems counterintuitive to the way that I grew up. I'm a old geriatrician, and I really like just talking to people. But in our current society, I think that lots of patients, lots of families of patients are asking for more electronic communication. And so whether it's through the technology, every hospital system essentially now has a patient portal. There's been a growing conversation in our broader healthcare community about how much access should we grant? Can I answer every question the patients have, or do I have to charge them for it? Is there a limit to the amount of time? When I go by and I see the patients, now there's a demand that in addition to talking to the patient, I also need to text the family members of the patient, and how does that that evolution work into my daily workflow? How does it work into my revenue? How does it work in terms of my my job satisfaction and the way that I communicate with people? And so I think that the demand for this communication is only continuing to explode. And now that I have a generation of children who refuse to answer my telephone calls, but will answer my text sometimes answer my text instantaneously. I think that we're only growing a future generation of individuals who are really responsive to this technology-driven communication and a desire to get the information in real time. And this creates challenges for physicians because I wasn't the physician on call last night, but I was receiving texts at 1 o'clock, 1:42, at 3 o'clock, and 3:30 in the morning from various individuals who had just various questions. And I don't know that they were demanding a real-time answer as much as just putting it into my work queue, but I get notified when I get those. And so I'm getting these questions from individuals like, hey, what about this nausea? What about this pain? It's like, oh my God, I can tell you the answer if you'd let me sleep when I come by tomorrow. But the 24-hour real-time environment that we've developed is something that the world hasn't developed great solutions for. So I talked to my leadership and said, well, the answer is turn off your notifications. Well, so then I don't get notified at all when their messages. But what if there's an emergency message? I mean, the technology doesn't triage this information well, and historically we've relied upon mechanisms to triage the physician's time. A secretary at the desk, a medical assistant, a nurse, and there are multiple layers. I also have residents and trainees who also field these calls, and so how do we build systems so that the world's questions are getting the kind of responsiveness that people are looking for? And I think that technology's got to be part of the answer. I think, again, my kids only talk to me by text during the day, but I grew up when I started medical school. I was in medical school when the dean came up to me and said, "Hey, Narcisse, we got this new thing today." I remember exactly where I stood. I was a second-year medical student. He said, "It's called the WWW." And so I only mention that because I'm not an old doctor. I'm mid-career, but I remind my students and my residents every day, or more often than they would like, that they live in a world where there's tremendous amount of information at their fingertips. And for us to get that information, we'd have to go walk to the hospital library to get it. But similarly, the patients had no access to us. I started medical school before I had a cell phone. I got a pager. It was a huge event in my medical school class when we got pagers. So I'm part of a generation that grew up before this technology was available and accessible. So can you imagine the physicians who are further in their careers than I am? The other half, of course, are coming along, but we're trying to teach them what to do, and we kind of almost don't know ourselves. And so this is a constant process, a constant thing that we're working on. As we have patients who are looking for this type of care, trying to engage with their primary care physicians, I heard some statements that sort of alluded to this. What kinds of things would you want a patient to say to their physician to get the kind of communication that they're looking for? Brother Young, you were talking about the example that you gave with your family members.
Yes. We try to keep it very simple, especially when we're working with communities and trying to improve healthcare literacy and consumer skills in the community. and that is, don't be afraid to ask. First, try to get some working knowledge like this. This is what we're doing here. What a patient-centered either medical home or patient-centered care is. For example, using what you just mentioned, Brother Narcisse, and that is access. To be a patient-centered medical home and demonstrate that you can deliver patient-centered care, one of the things you have to demonstrate is policies and procedures for access. How long do you take to respond to patients that call you during normal working hours? You have to have a policy for that, and you have to measure that. How long does it take for you to respond to a patient who calls you after business hours? You have to have a policy for that. You have to measure that. And then the other side of that is, in order to be a patient-centered medical home, you have to collect the data on how the patients perceive how well you respond to them. And so when you look at the patient-centered medical home model, and when you look at patient-centered care, it's really based on some of the things that you just mentioned. How responsive are you to the patients during business hours, after business hours? How long do you allow for a test to get back to you when you send the patient to a specialist? How long does a patient have to wait to make an appointment? Do you have same-day access available? Or do every patient have to make an appointment? And if so, how long does it take for that patient to get an appointment? When it comes to team-based care, do you have a policy and procedure in place that allows that patient to see the same team every time they come and not have to see a different doctor or a different team every time they come? So it's those kind of things that are all in the mix for patient-centered care. And once our communities, particularly communities of color, learn a little bit more about this, then they will be able to ask those kind of questions. Well, if I need care after hours, if I call you, how long will it take for you to get back to me? Or, if I make an appointment to see you for emergent or non-emergent emergency service, how long does it take for me to get in to see you? So all of those things are addressed in the patient-centered medical home model and in patient-centered care. Again, from the onset of our discussion, you are the boss. The patient is the boss. You're the captain of that ship. And so you just, with your knowledge and with your understanding of patient-centered care, you can really fashion and formulate how you're treated, how you're communicated with, and how responsive the practice is to you. I remember doing a presentation to a big group of physicians at the Rooster Tail in Detroit, and I asked, I was talking, and I asked them, I said, okay, I'm going to stop here. I want every physician in this office, I want you to raise your hand if a patient walks in your office right now and you've got your mission and vision and values on the wall. Nobody raised their hand. I said, now, if a patient walks in the office now, do you have your degree on the wall? Do you have your board certification on the wall? Do you have your college stuff all spread around the office? Everybody kind of laughed and said, well, yeah. I'm like, well, if that's the case, you don't deserve their business. Okay. Patients want to know, how you're going to interact with them and how you're going to make them feel better physically and not do so at the expense of them emotionally.
We've talked a little bit about some of the mechanisms of this, but does the patient really get something out of it? Is there really a relationship between the sense of social justice, racial justice, determinants of health, and the patient's outcome? Do we actually see that? And where do we see that? I have a couple examples that come to my mind. In your experiences, were there others that places where you could speak to that, the relationship between the determinants of healthcare and social justice?
I think that it was heightened during COVID, and it was placed on steroids during the George Floyd event and some of the other high-profile events during COVID and after COVID, I think there was a greater sense of fairness or disparity. There was a greater awareness of disparities. And for the first time, I began to hear more and more about racism as a social determinant of health. And before, we didn't hear that. I mean, I've been on the front lines of trying to help move the ball forward on healthcare equity for over 40 years. And, up until COVID and these other social events, we didn't hear terms like that. We didn't hear that there's a relationship between racism, stress, hypertension, renal failure, diabetes, obesity. Racism was never in the mix. And now, as a part of social determinants of health, racism has become part of that conversation. So I think there are some links there, Brother Narcisse. Unfortunately or fortunately, COVID illuminated a problem that has been around a long, long time. So I think there is momentum now. I just think we just got to bring the patients and the community a little bit more forward with knowledge and understanding of what they can do to help keep the ball moving.
I agree, Brother Young. I mean, I think it's starting to come to the forefront the last 2 years now with the advent of more chief health equity officers, both on the payer side and on the provider side. I know at Guidewell and through our affiliate, Blue Cross Blue Shield of Florida, we have a dynamic young African-American physician who has just been a pit bull in terms of looking at health disparities and some of the causes of those. And so we look at everything from food insecurity, looking at housing issues, poverty, as Brother Young pointed out before, health literacy. And we've seen the discrepancies there in terms of health outcomes related to health literacy of individuals. So, but looking at a lot of different areas there that are driving some of these disparities that we're beginning to measure a lot more, and having a focus on them, which is a challenge right now. Brother Pierce and I are both in Florida right now, and there's a lot of pushback on doing a lot of kind of DEI and issues that really focus on there. But if we're going to make the entire population healthier, that's just one of the things that we have to do. We have to look at, there's no one size fits all. And so, that is the point and the purpose of the culturally competent care and health equity, from my perspective, is that we have to do that in order to reach all the different populations if we want to make a impact on the whole.
I think that there's been a long recognition that there are different outcomes by in various groups. The African American group, other groups of color have worse health outcomes on a whole host of topics, from diabetes to heart disease to cancer. And I think that for a long time, the conversation has really focused around, first, poor genetics, which is something obviously no one really has much to control, but also there's been a sense of blaming the victim and saying that this is a function of poor health choices, poor behavior choices along the way. And I think that there's a growing sense and that doesn't really cover the whole story, that questions of how we work as a community, how we interact as a community may seem to have some role. Maternal health, maternal outcomes is the place where I've seen a tremendous push around this kind of conversation, where there's a recognition that individuals of color will have a worse outcome regardless of their socioeconomic status, regardless of their educational status, regardless of you pick it, a behavior, prenatal. They just seem to have worse maternal outcomes and appropriate birth outcomes. So I think that there's a recognition that there are other features, other factors, and the way that we interact with individuals, the stressors that puts on people may have a significant role. And so I think that this is where having cultural competency becomes oh so important in terms of our interactions with patients, because regardless of, you're not not everyone's going to be able to have a physician that matches their own demographic. But I think it's important that everyone have a physician who understands and is willing to reach out and try to build additional relationships and ask questions. One of the things that I've been teaching my residents, and my residents come from a panoply of ethnic and racial backgrounds, is to ask the patients questions about where they're from, what they enjoy, some things that are challenging to them. And it sounds like chit chat, it sounds like basic social interactions, but these types of things are the types of questions that we would ask each other when we meet in a social environment. And now we're trying to bring those same kinds of social graces, as my grandmother would say, to our interactions when I'm wearing my white coat instead of at a cocktail party or at a picnic. So those are the kinds of things that I think are growing in recognition. We still see that African American households have a significantly lower net worth compared to others. Do we see that financial disparity leads to access disparities and ultimately to health outcome disparities?
Now, this is just obviously my opinion, but I would say yes, absolutely, right? Household income and kind of, what you earn obviously affects insurance coverage as one good example, right? So are you on commercial coverage versus Medicare or Medicaid? That inherently is going to affect access to care, right? What type of physician can you see? What type of hospital you can actually access for care? So inherently, yeah, that does have a downstream impact, in my opinion, on health equity. And that's how I kind of look at it.
I think
I agree with just from an insurer side. You have two situations where one, individuals, even if they are covered, a lot of times they are underinsured, and so that deductible that they have may be a deterrent from them getting the preventive care that they want. So that's a big transition that we're trying to make from a Blue Cross Blue Shield perspective, is to remove some of those financial barriers to the basic primary care, the pediatric care, the geriatric care that people think about, that keeps them from getting those screenings, those important tests that they need, which cause bigger issues down the road.
I would like to add that, the number one reason for personal bankruptcies is healthcare costs. And like when we're working with human resource professionals and business owners, we try to show them where people of color are disproportionately affected when businesses and organizations move some of the healthcare costs over to the employees. And given that in many organizations, people of color are not at the top rung of the organization, they're somewhat in the middle or lower, a shift in healthcare costs to them is it could be catastrophic in some cases. So one of the things that we try to work with them on is, if you have to shift some of the cost to the employees, give them the skills to become good consumers so that they get the most out of every dollar that comes out of their pocket and every dollar that you spend on their behalf. So yes, there could be some financial hardship associated with some of the financial burdens that are put on people of color from organizations, and also that coupled with some of the other financial challenges that they may face just from day-to-day living could be a couple of compounding factors.
How can we better prepare our patients for understanding the healthcare expenses, getting more transparency, so they can look for their future healthcare with their current resources?
A couple things. One, I would suggest working with your health insurance plan on developing a personal emergency plan. Right. So if something happens, where would you go for care to make sure that there's something in network? There are over 75 different services that are zero cost to the employee or to an individual there that are covered by the insurance plan. Getting a better understanding of what some of those things are. and then just working more closely with the insurance. They have tons of people there that are available to call to say, hey, I'm thinking about this, or this may be an issue for us. We're looking at having a potential addition to our family. I may need a surgery here. How can you help me? Can you explain to me, what some of this will cost? Where will this go? The biggest challenge that we have there is health literacy. Usually people, and we're doing the testing right now, the higher people have in terms of health literacy, the less their costs end up being, and the better their outcomes end up being. So it's really, to your point, Brother Narcisse, so the communication up front, realizing that if the insurance company is calling you on there, it's not because they're trying to collect a bill from you. More than likely at this point, the way the healthcare is moving, they're trying to keep you healthier in a way.
Yeah, your healthcare obviously is one of those industries we got a long way to go in terms of transparency, right? You think about you book an airline flight, you know exactly how much you're going to pay before you book it, right? You take your car in to go see the mechanic, they diagnose and tell you exactly how much it's going to be. Healthcare, show up at the hospital or maybe your physician office, you might be on your own, right? But there's ways you can kind of get at least an estimate. A lot of people aren't familiar with it, but January 2021, CMS actually started requiring hospitals to post their prices online. And I can guarantee you, I can say we're pretty much confident, 100% of hospitals across the country have not complied with that. And some hospitals have put it so far in their websites, it's hard to find. So the charge masters, a lot of hospitals are actually there. It's on the websites. And so, you connect that with your health plan, right? So a lot of people also don't read their explanation of benefits, right? You get it every year during open enrollment. Typically when you sign up for your employer, it tells you exactly how much you're going to pay for going to the ED versus urgent care and inpatient stay. They'll typically give you a percentage. So it's not a perfect science, but at least you kind of got that, and you know what the charges are going to be from some of the hospitals. Some of the other opportunities for consumers to really take advantage of, obviously, ambulatory surgery centers. They typically have more straightforward fee schedules in terms of being a little bit more transparent. The hospital, I definitely say that I'm a hospital administrator, and I want you to come into the hospital. And then also retail clinics, right? They got a lot of publicity starting around 2005, 2006. But one of the things that was really great about retail clinics is the prices are posted when you go into the centers. And so, that's one kind of step in the right direction in terms of transparency. And, there's a lot of other opportunities. We'll probably talk on and on about this, but transparency, we've got a long way to go.
Well, what if you're talking about a low income community, someone who's historically accessed a federally qualified health clinic? How do these issues come together with cultural competency and patient-centered care?
That's a great question.
A year or so ago, HRSA, which is the organization that oversees the FQHCs, they gave federally qualified health centers or community health centers a financial incentive to transform into patient-centered medical homes. So you now can go to a FQHC, which pretty much has a mission and is tasked with serving underserved and poor populations. You can get patient-centered care there now because the HRSA has required them to become patient-centered medical homes. The other thing is that with federally qualified health centers, they have to take you. They can't turn anyone away because of the inability to pay them. They work off of a sliding scale, but they can't turn anyone away. I've worked with a lot of FQHCs, and I will tell you, they are some well-run operations, and they are really focused on patient-centered care as part of their mandate by the federal government.
Yeah, I'd also like to, one of the things that came out of the American Rescue Plan was an expansion of a lot of the subsidies that go into for commercial healthcare coverage that started from the Affordable Care Act in 2010. And that has opened up the door to millions of additional people having access for, in some instances, $20 or less per month for coverage. And within there, a lot of those plans will cover transportation, different areas that can kind of help people get to better care that they need. I do think that the FQHCs fulfill a very strong purpose in a lot of these communities, but I think also too, I think it's complementary. I think they can all work together.
Well, we've had a robust conversation this evening, covered a lot of different topics. I'd like to go around the the room and get final comments from each of you. Where do we go next in a minute?
I'll start. I'll say that where we go next is just building knowledge, building understanding of this new healthcare system that is evolving, one that is more competitive driven and more than and more patient centered driven. I just think that the big gap that exists right now is having consumers who just don't have the information or the training or the understanding of this new model, this patient-centered model, and how to use it to their advantage. So I think, from my experience, everybody that I run into on the provider side is talking about patient-centered care, culturally competent care, healthcare disparities, health equity, and so on. But then when you go into like a church or a community center or, a place where non-provider people congregate, and you say patient-centered care or patient-centered medical home, they look at you like you got two heads. So I think it's just a matter of linking the understanding that the providers have with the understanding that the consumers have, and then we'll have a pretty good market in which to operate.
So I'm going to give you everything we've discussed tonight is vitally important, right? Health equity, access to healthcare, consumerism, patient-centered care. The reality, I'll give you my perspective from a health system, hospital provider perspective. The reality, a lot of hospitals and health systems are struggling right now to stay open and stay alive. And so as much as we might think it's a priority, it's not necessarily the first priority right now. And so where I'm going with that, we got to get people really engaged. Why is this critical? Why is this important? And I think that's really the next step. I saw a few, thoughts in the comments about, well, physicians aren't getting paid for this. And I brought that up earlier, right? A lot of physicians, you start bringing this up to them, what am I getting paid for this? What's the value for me? And so I think we got to get past that, get people engaged in health equity, access, consumerism, and getting people back to 2020 when it was a big deal. Topic discussion.
I'd say two things. One, be informed and be collaborative. Informed, before you go in and you're thinking about something, just write down your list of questions. What are some of the things? Because this is a partnership between you and the providers. Second, be collaborative. I have a new physician and we're beginning to bond a little bit more now from a PCP perspective. We're walking through not only, the history of some of the things I had in my previous systems and when I was living in Houston, in the Epic system of my health history, we started walking through my 23andMe numbers. So he's looking at, some of the different things in terms of my health history there, my genetic history. So the more information we can share with the providers, the better they can do a job of kind of making sure that we have a very customized plan to keep us healthy.
I'm at Houston Methodist in the Texas Medical Center, and we talk about engaging key stakeholders. We talk about increasing underrepresented group diversity. We talk about increasing and reinforcing anti-racism, anti-bias, diversity, equity, and inclusion. We talk about developing resources for all employees to learn, to discuss, and to share their perspectives, and measuring the community impact. So I belong to an institution that's I'm very proud of the strides that it's taken, particularly of late. And I think that it only shows that while we've done so much, there's so much more to do. And so I think that the message that I've heard from all the panelists tonight is that you really must start by, as a patient, as a consumer of your own healthcare, you have to learn about the issues that impact you, that potentially could impact you, things that you may or may not have learned about. That's one of the things we've been proud of with the Surgeon General Initiative. I'm the chair of family education. Our series is usually Thursday night, not Wednesday. I apologize about today with the switch. I'm sure that's confused some, but I think that we're trying to reach out and educate, bring perspectives, bring speakers that can share their knowledge. And I hope that that's something that is of interest to you. If it is, the YouTube channel is Sphinx TV, and our Alpha Phi Alpha Fraternity Incorporated YouTube channel is populated with a number of the presentations that we've given in the past. We look forward to doing those in the future. Our next presentation is coming up, again, usually Thursday nights. It's going to be the Thursday coming. at 6 p.m. Central. I thank you all for your time, your attention, your patience with us. I'd like to thank General President Lonzer for allowing us to bring this initiative. You've heard from Surgeon General Sterling earlier this evening. It's his vision that we begin this communication and this message with you. It's my honor and privilege to take a moment to do this on a regular basis. I wish you all a blessed evening. Thank you and good night.
Good night.
Brother